Thanks a lot. So I'm grateful for the opportunity to present this data on behalf of our research team. So people living with HIV are at greater risk for being infected with influenza. They're sicker for a longer period of time, and they're more susceptible to severe illness and death from influenza illness. Okay? So, of course, one way that we can protect these folks is through vaccination. Now, there's multiple publications in the pre-HART era looking at the immunogenicity of non-adjuvanted vaccine in this population, and universally they've been disappointing as far as the seroprotection and seroconversion rates achieved. In 2008, I led a Canadian HIV Trials Network study funded by PCIRN and the OHTN that looked at non-adjuvanted flu viral in a randomized clinical trial. We looked at single dose compared to single dose followed by a booster a month later. And we also looked at double dose followed by a double dose booster. Okay? And although the booster dosing improved immunogenicity slightly, we still found that seroconversion and seroprotection rates were only somewhere in the neighborhood of 50 to 60%. So clearly this just doesn't cut it in this population that is at risk. Okay? So we asked the question as to whether the addition of an adjuvant to an activated influenza vaccine would achieve superior immunogenicity. Okay. The design of this study was a phase 3 prospective randomized clinical trial. We evaluated safety outcomes and immune responses to the H1N1 pandemic strain vaccine. We conducted the study at 4 Canadian HIV Trial Network / PCIRN sites in Ottawa, Toronto, Montreal, and Halifax. And we used 2 dosing strategies. The first was a single dose of the pandemic strain adjuvanted vaccine, and the second one was a dose followed 21 days later by a booster dose. We intended to recruit 150 consenting HIV-infected adults between the ages of 20 and 59. Okay. Subjects were stratified by viral load suppression and age bands. And as I already stated, they are randomized 1-to-1 to the 2 previously described interventions. Okay. Irapanirix was used as the adjuvanted vaccine, and you're all familiar with the characteristics of this, so I won't repeat it. Okay. For safety outcome measurements, memory aids were provided to our participants, and illness symptoms were documented at day 0 to 6, as well as to 7 to 21 days following vaccination. Okay. We focused on local and general adverse events, so specifically injection site, pain, redness, swelling, as well as fevers, and then the general symptoms that we typically associate with immunization. Okay. We also collected data on flu-like illnesses and tried to collect specimens to identify influenza infection if it occurred. With regards to serologic outcomes, we collected blood at baseline, day 21, day 42, and at month 6. And we assessed for hemagglutination inhibition antibody titers to the H1N1 pandemic strain. Okay? And we interpreted it according to internationally accepted standards. Okay? And these are the results. We ended up enrolling 150 patients as planned. 83% were male, most were white, and 85% were on antiretroviral therapy, and the 84% of these patients had HIV viral loads that were fully suppressed. So I think that's very important when you're interpreting these results. These were well-treated patients on antiretroviral therapy. Only a small handful had CD4 cell counts below 200. Okay. Most of these patients, 87%, had received an influenza vaccine the previous year. Okay. And a small handful of these patients were co-infected with hepatitis B and or hepatitis C. Okay. Now, these are the results. If you first look at the seroprotection data, Group 1 are the individuals that received booster. Group 2 are the ones that received a single dose. Okay? And at day 21, so this would be 21 days after both arms received a single dose of vaccine, you can see that 80% achieved seroprotection and 74% achieved seroconversion. Okay? And as you would expect, there is no statistical difference between that. Now at day 42, you can see that in those recipients of a booster dose, the seroprotection rate increased from 83% to 94%. Okay? Whereas in the group 2, who did not receive the booster, you can already see that the seroprotection levels are starting to decline. And this was statistically significant. As far as seroconversion, you can see the same findings. The seroconversion rate increased to 86% in the booster recipients and declined to 66% in those who did not receive the booster. Again, significant. And you see the same findings with geometric mean titer and geometric titer ratios. Okay. Now, if you focus on the month 6 data, you see that for both groups, the seroprotection and seroconversion rates began to decline. They were, at least there was a trend in favor of retaining the seroprotection and seroconversion rates in a higher proportion in those recipients of booster. Okay. We evaluated predictors of seroconversion, okay? And we assessed whether the patients were on HIV therapy, whether their HIV viral load was fully suppressed or not, their CD4 count, whether it was greater than or less than 200, age, sex, weight, viral hepatitis co-infection, history of prior influenza vaccination, lack of baseline influenza seroprotection, and randomization group. Okay? So all of that was assessed by univariate analysis. And then in our multivariate analysis, we included the randomization group, whether the HIV viral load was suppressed, weight, and co-infection. Okay? And as you can see, at day 42, receiving the booster dose was predictive of seroconversion rates. Okay? And having your HIV viral load fully suppressed was almost statistically significant at a p of 0.06. Okay? At 6 months, you can see that those patients with suppressed HIV viral load were more likely to retain seroconversion compared to those people without virologic suppression. And as it turned out, that was even more important than whether they received a booster or not. Okay? Also, interestingly enough, increasing weight was negatively predictive for retaining your seroconversion at 6 months. Okay. Both dosing strategies were well tolerated. 85% reported some type of local or systemic vaccine-related symptom, but all but 10% of these resolved by 6 days. What we noticed is that in those receiving a booster dose, the likelihood of developing an IE actually declined to only 65%. There were 6 severe adverse events reported in 4 of our study participants, and they are described on the slide, none of which we thought were related to the vaccine itself. There were 5 influenza-like illnesses reported over the initial 42 days period, and 3 influenza infections were confirmed. Of note, all of these 3 infections occurred within the first 10 days of immunization, and the study, day 0 was about November 1st, so as you recall, there was lots of flu activity until about mid-November, and then it stopped. Okay. So in conclusion, we found in this study that single dose and booster dose Panrix was well tolerated in our HIV study participants. Immunogenicity was increased considerably with a single dose of this adjuvanted vaccine compared to historical data. Okay. All key measures of immunogenicity were further improved with standard dose plus booster compared to the standard dose alone at day 42. And I think what we can conclude from this is that use of the adjuvanted vaccine and booster represents an important approach to increasing immunogenicity in this vaccine hyporesponsive population. So I'd like to acknowledge and thank PCIRN and the CTN for their support of this study, as well to GSK, who provided some financial support as well. And our research team is listed below to thank you. So thank you to each of you for your assistance with this study. Thank you.